Good morning. Thank you, everyone. Thank you, Mr. Chairman. So in the next 20 minutes or so, I'm going to try and take a shot at how can we achieve an accurate or precision fluid balance during RRT in our critically ill patients. So if you look at the data on the relationship between fluid overload and outcomes, there have been numerous studies that have shown that depending upon the definition that have been used, a fluid overload of cumulative fluid balance of greater than 5% or 10% are independently associated with increased risk of death. And this is not a trivial problem. I mean, the prevalence of fluid overload in the ICU, depending upon the studies, is huge. I mean, this is like 40 or 50%. So this is the elephant in the room when you consider patients with AKI and the impact it has on increased risk of death. And again, the mortality, depending upon which study you have, is more than third to one half. And no other ICU syndromes have this much amount of mortality, currently. So furthermore, this risk of death is not just confined to the hospital. When you look over 1 year, you can see that significantly patients who are fluid overloaded have incremental risk of death. That's 2 to 3 times when compared to patients who remain in even balance or in a negative fluid balance. This risk of death associated with positive fluid balance or fluid overload is not constant over time. It kills a lot of people early on after ICU admission. As you can see here, any data about this, above 1 indicates that positive fluid balance is associated with increased risk of death. And although the hazard associated with fluid overload on mortality decreases over time, nevertheless, it stays above during that entire year. The one key thing to note here in the study is that many prior studies that have looked at fluid overload have always compared positive fluid balance to that of patients with negative fluid balance. And if you compare anything, any positive fluid balance, especially when you compare it with negative fluid balance, obviously positive fluid balance would look bad, and the risk, we would overestimate the risk associated or the hazard associated with positive fluid balance on mortality. So we then ask the question, what is the relationship between positive fluid balance when compared to even fluid balance in the ICU, and also what is the benefit of negative fluid balance when compared to even fluid balance in the ICU? And in these studies, we looked at even fluid balance as a comparator. So when you look at negative fluid balance and you compare it with even fluid balance, you can see here very clearly that negative fluid balance, if you compare it with if you compare the negative fluid balance with the positive fluid balance, clearly negative fluid balance is associated with lower risk of death, and on that relationship persists over 1 year. On the other hand, if you look at negative fluid balance in comparison to even fluid balance, we found this variable relationship in which we found that negative fluid balance was protective for mortality only up to 60 days after ICU admission. And after this, the negative fluid balance was associated with increased risk of death that persisted over 1 year. And we were very intrigued with this finding, because many studies that have compared negative fluid balance with positive fluid balance thought, okay, we should all keep everyone negative fluid balance. It looks really good when you compare it with positive fluid balance. But our study, raises the question about who should be the comparator, who should we compare it to when you think about, fluid balance, because there's a group of about 30% of patients in the ICU who remain euvolemic or who remain in even fluid balance or euvolemia during their ICU stay. And if you compare either positive or negative fluid balance to that euvolemic group, you get different risk estimates for either protective effect of negative fluid balance or hazard associated with positive fluid balance on mortality here. So we were very intrigued by this finding, and we did a number of sensitivity analysis to show that this is actually the case. When in negative fluid balance, if you look at overall, you may not find a difference at all when you compare. But when you parse it by the risk of death over time, as shown in this model, you can see the benefit is only for a short term. And this has implications for care, because a lot of the recommendations for managing ventilated patients, recommends to keep the patient dry and to, push them to negative fluid balance to get them off the ventilator. And we think that the short-term benefit of why these patients survive, with negative fluid balance is because we don't let them die in the ICU. We provide organ support. We keep them on the ventilator. We do all sorts of organ supportive therapies to keep them going. But yet you can see that there's a higher hazard associated with long-term negative fluid balance. So we were intrigued by this finding, and we wanted to find out why this might be the case. And we looked at other studies that looked at this and provide evidence to suggest that negative fluid balance may not be so good. So this is the data from the FACT trial, and FACT trial was funded by the OddsNet group in the United States that compared two different fluid regimen strategies in patients with ARDS. Patients with ARDS were randomized to a liberal fluid strategy based on a protocol and a conservative fluid management strategy comprising of using diuretics to keep them as negative. And this is the fluid balance you can see here, that patients who are on the conservative fluid balance were on average about 200 mLs negative in the first 7 days after ICU admission. Now, the primary trial didn't find any difference at all in mortality between the two groups. But however, they did find that patients who got randomized to the conservative fluid arm actually came off the ventilator early. And so based on this finding, they recommended to have all the patients on a negative fluid balance or somewhat dry while they're on the ventilator. But yet, if you look at the long-term 1-year outcome data on patients who were randomized to conservative fluid balance, you can see among the patients who got randomized to conservative fluid balance, the impaired hazard, there's an impaired or worsening of the neurocognitive function at 1 year. Now, it's important to remember that 50% of the patients who were enrolled in this trial died by 1 year. So this is outcome assessment in the remaining 50% that survived up to 1 year. And you can see that there is a hazard associated with keeping the patient really dry. And again, this is also borne out by loss of executive function and then neurocognitive impairment at 1 year in survivors of severe ARDS who were randomized to a negative fluid balance or a very conservative fluid balance. Furthermore, this is the data from outpatient hemodialysis literature that actually shows taking too much fluid off the patient or taking it too rapidly associated with increased risk of both all-cause mortality as well as cardiovascular mortality. In this study, you can see that they compared an ultrafiltration of less than 10 ml per kilogram per hour to that of 10 to 13 and greater than 13. So when compared to less than 10 ml per kilogram per hour, greater than 13 mLs per kilogram per hour was associated with increased mortality. Furthermore, if you look at the more recently published that just came out in the last couple of weeks, and this week's New England Journal of Medicine, looking at restrictive versus liberal, the RELIEF trial, looking at two different fluid regimens and randomizing patients who are undergoing high-risk abdominal surgery, you can see that in the liberal fluid group, the patients got 10 ml per kilogram at the time of induction of anesthesia, and then about 5 ml per kilogram of fluid subsequently during the operating room and then the post-operative period, compared to that of a restrictive regimen of 5 ml per kilogram during induction of anesthesia and to 1 to 1.5 mLs per kilogram per hour subsequently. You can see that clearly patients who got randomized to the liberal arm actually received more fluid, and they were more somewhat positive fluid balance when compared to patients who got randomized to the restrictive fluid balance, were only about 1.3 liters positive when compared to 3 liters. Now, these are not critically ill patients in the ICU, but nevertheless, this sort of proves to the point that if you don't give fluid to a patient who actually needs fluid, then you can actually worsen the outcomes. And in fact, this study showed there was an increased risk of acute kidney injury in the patients who got randomized to the restrictive fluid management strategy. And in fact, if you look at all the ERAS protocols right now, they all recommend sort of a restrictive fluid regimen, not to administer too much of fluid. And yet, you can see there was an increased risk of AKI in this study. Also showed that there's an increased risk for renal replacement therapy who got randomized to restrictive fluid regimen. So the reason I'm mentioning is that you can't keep the patient too wet or too dry, and we have to get them into the right spot. And what is that right spot? It's very difficult, and it has to be individualized, and there's no data to guide us what is the right spot in an individual patient. And you have to look at the patient. When a patient is in shock, admitted to the emergency room with severe hypotension and shock, you have to give them sort of as much as you want to, to save their lives. Because the benefit, the attributable benefit of administering fluids is time dependent. It could be the same amount of volume that could be beneficial in the early phases of resuscitation, if persistent and present subsequently over time, may be harmful. And we need to think about that. Yes, we've given 5 liters of fluid when the patient came in, when they're on severely septic and in shock, but 2 days down the line, 3 days down the line, that fluid hanging out in that patient who already have AKI may not be a good thing. And we need to sort of individualize where each patient is. And you can see that in this cartoon that we proposed here, if you give too little fluid, there's organ injury by organ ischemia, and then if you give too much fluid, there is organ edema that subsequently causes organ dysfunction. So what happens when you put these patients on renal replacement therapy? We noted this striking finding in which if you take a patient with positive fluid balance and you start renal replacement therapy, for some reason you can see that the hazard associated with positive fluid balance is attenuated. In other words, you can see that in this graph, this is the interaction between positive fluid balance on mortality in patients who receive renal replacement therapy compared to patients who don't receive renal replacement therapy. And you can see that the hazard actually changes to a protective strategy. In other words, removing fluid is associated with improvement in outcomes. However, what we don't know, unlike the RRT studies that have made recommendations on solute clearance, is how much we should remove, what is the rate at which we should be removing fluid, when we should start, when we should stop. All of those questions remain unanswered. So in the ADKI that was convened about 2 years ago, looking at making recommendations for CRRT and using CRRT to deliver precision therapy, or so-called precision CRRT, a conceptual model was proposed in which the fluid balance of the machine as well as the fluid balance of the patient has to be integrated. And it's very common, a lot of times, even in our institution, that everyone is getting 100 ml per hour of fluid removal in CRRT. And those volume management is not based on an hourly intake or output of fluid that's coming out of the patient. You can easily imagine this situation. If you have a patient who's receiving 200 mLs of fluid given over a period of time, and you're removing only 100 mLs on CRRT, people think that, okay, you're removing 100 ml of CRRT, but not taking into recognition that the patient is getting 200 mLs per hour, which means that every hour the patient would be 100 mLs positive. So at the end of 24 hours, the patient would be 2.4 liters positive, despite you taking 100 mLs an hour. So it's very important to integrate both the machine fluid balance, which is what you're taking out in the CRRT, with that of what is happening in the patient. And in fact, in this graph shows that if you're giving drugs, TPN, and other fluids, there are a lot of fluid that's going into the patient, and then the machine fluid balance that you're looking at, because it's showing the numbers on the monitor. And if you don't integrate it in a timely fashion, so in other words, you prescribe the machine and you don't look at it until it's like another 5 hours or 6 hours. And in our institution, people don't even look at it until it's like 12 to 24 hours, because they're so busy preoccupied with the other stuff. The patient is going to be fluid overload. So the more frequent evaluation, the most frequent integration of the patient and machine fluid balance, so-called the integrated fluid balance, allows you to get more tight control of volume management in patients on CRRT. And in fact, there have been observational studies that have actually shown, there's a data from the Picard study that shows that if you take a patient with fluid overload and start them on renal replacement therapy, you get a better management of volume when compared to managing those patients on intermittent hemodialysis. So in order to understand what the real world practice is in terms of fluid management, because there's a lot of paucity of data about what people are actually doing in the intensive care unit in volume management, we compiled put together this survey of 25 questions, and we in collaboration with about 10 critical care nephrology societies across the world in about 25 countries. We are currently conducting this survey, asking the physicians, nephrologists, and nurses on what is the management, what is their practice related to volume management in critically ill patients. And these are some of the preliminary results that we have here. So we asked the question, in your clinical practice, which criteria do you use the most for initiating intermittent hemodialysis or CRRT in a patient with oliguric AKI? What is the most common indication? And you can see that here, most clinicians indicated that either persistent oliguria or anuria is still the most common indication for removing fluid. Then we asked the question, well, how frequently do you monitor your volume management strategy in a patient who's on CRRT? How frequently you measure the net dose, which is what's going on in the patient, as well as what's coming out of the machine to evaluate to titrate your fluid management. And you can see only about 35% of the patients, clinicians actually evaluated their fluid volume management strategy in the ICU. And there was this wide difference. Some people evaluated only 2 hours, someone evaluated only 8 hours, and then there is like about 5 to 7% fluid balance was never said that they never look at the fluid balance on CRRT. So we were very intrigued by these results. Then we asked the question, what do you do when the patient gets hemodynamically unstable, like tachycardia, hypotension, increasing lactate? And again, there's a wide variation in what people actually do. So some people said we'll decrease the rate of fluid removal. Some people will say we'll stop it. Some people said we'll increase the vasopressor dose. And someone said we'll give you mannitol and albumin bolus. So like you can see, none of this is actually evidence-based, and then there's a wide variety of how people practice CRRT in the ICU. And this is exactly precisely what we sort of hypothesized going into the survey, that there would be this wide variation. But nevertheless, it helps to understand what actually people are doing. And then we asked the question, what is the barrier to fluid removal in an oliguric patient? As you can see here, patient intolerance, as you would expect, is the most common reason that clinicians said that was the barrier to fluid removal. But after that, you can see that these interruptions, trip to CT scans, trip to other stuff, the circuit breakdowns were the most common reasons why. So it's very similar to the problem of solute, clearance, because obviously if you can't clear solute, then you can't clear volume either. But nevertheless, it sort of brings up the point that when you're talking about solute clearance during CRRT, we all know that, it's really important. But you can really get a good control of solute clearance in the first couple of days. But after the couple of days, it's the volume management that persists, and it's problematic, then remains problematic until the patient either dies or recovers renal function, as it becomes challenging because of all the hemodynamics and other things that going on in the patient. Then we asked the question, what do you believe in terms of early fluid removal in a critically ill patient with oliguric AKI using either intermittent hemodialysis or CRRT? And about 80% of the clinicians strongly agreed that that a protocol to remove fluid removal early would be helpful or beneficial in improving the care of the patient. So we are doing some work related to the fluid, the intensity or dosing of fluid removal or control in critically ill patients, but we can't make any strong recommendations until further studies show that what we need to do at the bedside. But nevertheless, I would like to leave you thinking about this at the moment, in which positive fluid balance is associated with adverse events in critically ill patients, no matter who you compare it with, either with patients with even fluid balance or negative fluid balance. Negative fluid balance has a variable association with risk of death. It may be associated with lower mortality in the short term, but in the long term, you have to be very careful about what to do to your patient. And even like an average negative, keeping the patient really, really dry may not be the right thing to do in our patient. And you have to think about keeping the patient euvolemic. Euvolemia should be the goal that we should try and try to achieve. And then about only 1/3 of the patients actually had their fluid balance monitored hourly during CRRT. In other words, the remaining 2/3 of the patients, there was no form of a monitoring done during volume management. And then I would leave you by the statement saying there's a wide variation that exists in how fluid removal is prescribed and practiced in the real world. Thank you very much.